Thank you, Dr. Deepak. Now, what I'll be covering in next 30 minutes or so is that there are two things. What we are going to do after post-cardiac arrest. First part is simple because already there are guidelines, but in the second part we need to put our thoughts exactly what is required in future, and lots of prospects are there as far as research is concerned in the second part, because still we are in the gray zone and we need to identify what exactly has to be done for those kind of patients who are undergoes cardiac arrest and where we need to control with TTM. So this is the algorithm which is given by American Heart Association, Adult Immediate Post-Cardiac Arrest Care Algorithm 215. And all of you have done this course of American Heart Association, and all of you, I think, know what exactly need to be done after return of spontaneous circulation. Exactly the oxygenation and perfusion, these are the two most important things which we do. And after getting that, by using a ventilator and using of inotropic agents, what you do a 12-lead ECG and see the status. If there is an ST elevation MI, then immediately shift the patient for cardiac angiography and cath lab. If the patient is non-responsive, then you proceed for targeted temperature management or therapeutic hypothermia. And again, depending upon the recovery of the patient, you proceed whatever is required. And in the meantime, you need to exclude also the 5H and 5T, which are very important to tell about the cause of cardiac arrest. And if we rule out and if we manage the cause appropriately, then definitely the outcome is going to be much better. Now, these are the recommendations which has been given by AHA. There are 15 committees worldwide: American Thoracic Society, American Cardiac Society, American Heart Association, ILCOR, or Indo-European Society. All of them, they combined and finally gave these recommendations, which are again modified in the year 2015. What is to be done for patients who undergoes cardiac arrest, and after that what is to be done. So it includes, there are 10 different things like cardiovascular care, temperature management, what is to be done with the respiratory system, pulmonary embolism if it happens, what is to be done, what is to be done as far as sedation is concerned, and then the most important thing, how to tell about the prognostication of the patient. That is the most important thing, because many times you see that patients attendant are only after thinking what is going to happen to my patient, whether he is going to survive or not. So that is the most important part. And finally the organ donation, and that is another important thing which we should consider. So recommendations were based, as I said, there are 15 committees who finally concluded all these recommendations, and they gave all the recommendations on the basis of classes, class 1, 2, 3 and so, and then level of evidences, whether it is a randomized trial, non-randomized trial, or of the level of evidences are poor, then they said limited data are available, or if the data are not available, then what is the expert opinion says. So in that way, they have divided all the recommendations which has come. So the key recommendations which has come, I think all of you must remember, because these are very important key recommendations. First is that emergency coronary angiography is recommended for all patients who develop ST elevation MI, following which after cardiac arrest, and during if this targeted temperature management has been given, even after that, if the patient has got this changes in the ECG or ST elevation or ST depression, these patients must go coronary angiography and go for a definitive management. Now, a range of temperature which has been described, that is between 32 to 36 degree or 33 to 36 degree, between which exactly we need to maintain the patient's temperature, and that is what we call as a targeted temperature management. We will see it later on. If the patient develops fever, then it should be controlled immediately, and prevention of fever is very important. Then hypotension should not happen for any patient, and that is why immediately, that is said in the algorithm, we saw that antihypotensive agents in the form of epinephrine, norepinephrine, dopamine must be started immediately after the cardiac arrest. And prognostication, as I said, is very important part, should be explained not sooner than 72 hours. Whatever kind of cardiac arrest the patient has developed, you should not give any explanation or any positive opinion about the patient to the attendants before 72 hours. And if all the patients must you must counsel them so that they can become a potential organ donor. So these are the key recommendations. Now let us see one after another what has been the development which has come up in 2015 AHA recommendation as far as cardiovascular care is concerned. As I said, there are nearly 10 points on which we are going to talk about this. So first is cardiovascular care. They say that a 12-lead ECG should be obtained as soon as possible. That already was there in the algorithm immediately after return of spontaneous circulation, and you have to see whether ST elevation is there or not. If the ST elevation is there, immediate coronary angiography and whatever the definitive treatment has to be done. And that carries a level of class of recommendation of 1 and level of evidence is B. Then coronary angiography should be performed emergently, immediately for all out of hospital cardiac arrest, whether it is an ST elevation or non-ST elevation MI, who must go for an coronary angiography. Here again the class of recommendation is 1 and level of evidence is basically B, that is non-randomized control trials are there is no randomized control trial. Then again, in reasonably selected patients who are comatose after the patient comes from out of hospital cardiac arrest, and here you see that there is no ST elevation on the ECG, and that also is recommended that they should also undergo an emergency coronary angiography, and that carries a class of recommendation of 2A and level of evidence again it is a non-randomized. Then again it is reasonable for post-cardiac arrest patients for whom coronary angiography is indicated, means pre-existing some problem is there and you come to know that yes, he was one of the vulnerable candidate, and here you must proceed for a coronary angiography, and the level of evidence is again class 2A, and as I said, level of documentation are very less, so there is no randomized or no non-randomized control trial. Level of evidence is little bit low. And then avoiding and immediately correcting hypotension during the post-resuscitation period, that is again a very important thing, and that carries a class of recommendation 2B. Now what about hypothermia? That is what we are going to talk today in detail about TTM. It is recommended that all comatose patient, whether it is in hospital, out of hospital, after return of spontaneous circulation, they must get some kind of hypothermic management. If the patient has developed VF or persistent ventricular tachycardia, if the rhythm is shockable, then it is a definitive requirement. If it is non-shockable, now the level of evidences are little bit low, but still it is said that class 1 evidence, class 1 recommendation is there that you must do it, although it has come from expert opinions, but they say you must do it. Now again, the level of temperature which is to be maintained in between 32 to 36 degree, and that is why it is called targeted temperature management, where you need to keep yourself, your patient. So, and another thing, that how long you are going to give this therapeutic hypothermia or targeted temperature management. There is again a lots of debate, 24 hour, 42, 48 hour or 72 hour, but at present the recommendation is that 24 hours has to be the time period for which the TTM has to be given. Then pre-hospital cooling, whether the patient who has developed a cardiac arrest outside the hospital, do you want to start a cooling from there only? No, it is not recommended. They say once the patient reaches the hospital, thereafter you should think of cooling the patient. And then fever should not occur. For any patient who is developing fever, the mortality goes in exponents. So that is why fever should not develop in these kind of patients. Then what about neurological care? An EEG should be taken immediately and on a continuous basis for this kind of patient, and that carries again a class 1 recommendation. And anticonvulsant regimen, there is no difference. If the patient convulses, All those which are used routinely for as an anticonvulsive agent in the ICU, they should be used immediately to control the seizure. Further, once it has happened, should not develop further because the recovery becomes remote, more and more remote once you avoid these things. Now, and the routine use of coenzyme 10, which is usually a drug which is used in United States, not available in India, but it has its role has is uncertain. We do not know. What about respiratory care? Ventilation and oxygenation, they say, that PCO2 has to be maintained within normocarbia 35 to 45. That is a physiological range and that carries a class 2B recommendation. Again, I say there is no randomized controlled trial, only basis on the level of evidences are low. Then to avoid hypoxia, the patient should be put on ventilator and oxygen concentration should always be kept above 90. SpO2 should not. You should try to maintain a 99% hemoglobin saturation. That is the most important thing. But in any circumstances, it should not come below 94. So 94% is the lower limit to which you can go. You try to keep the oxygen percentage saturation always above that, or you try to keep oxyhemoglobin saturation as much as possible. Now, what about pulmonary embolism if a patient has developed? The recommendation says that immediate thrombolysis is required if a patient has developed pulmonary embolism. And class of recommendation is 2B. What about sedation? It says that considerable sedation and analgesia as and when required should be given as per the protocol of ICU. Whatever sedation protocol you are following in ICU, as such, there is no specific recommendation which sedative or analgesic is to be used. About glucose control, there is no recommendation. You say that hyperglycemia, even the patient can stay in hyperglycemia as such, there is no recommendation for tight glucose control or a glucose below 200 or 150 like that. So, these are all organ specific and problem oriented recommendation from American Heart Association. But what about the timing and outcome prediction? This is the most important thing. The earliest time for prognostication using clinical examination patients treated with TTM where sedation or paralysis could be a confounding factor, then 72 hours after return of normothermia. So once a patient has been reversed from targeted temperature management to normothermia, you must take at least 72 hours to tell the patient what is the prognosis. And this is the earliest time to prognostic neurological outcome using clinical examination in patients who develop or who has been given targeted temperature management for 72 hours. And again, prognostication can be even longer than 72 hours after cardiac arrest if the residual effect of sedative analgesic you think is there. So you can always keep it prolonged, make it 96 hours or make it 120 hours. There is no problem. But before 72 hours, you should not tell patients, family members anything. Now, to prognosticate outcome, there are few important things which you need to know because all these things combined when it comes in your mind, when you think about all these things taken all together, then you can say what is going to happen to the patient. One is EEG, SSEP, then there are some biomarkers which are available nowadays, and then clinical examination, obviously the first thing, and then what radiological evidences say. So when you combine all these things, then only you can tell exactly what is going to happen to your patient. So first of all, the clinical examination. What are the things which are going to see in clinical examination? In comatose patients who are not treated with targeted temperature management, absence of pupillary reflex for more than 72 hours. It is a strong indicator the patient has become brain dead and carries a bad prognosis. And it carries a class of evidence 2A. In comatose patients who are treated with targeted temperature management and there is an absence of pupillary reflex after 72 hours. Here again, this is a clinical finding on which the basis of which you can say the outcome is poor. Then it is recommended that given their unacceptable false positive results, APR is false positive results, here is a very high in this up to 10%, the finding of either absent motor movement or extension movement. You see many a times you see that there is no motor movement. So motor movement is a poor predictor. It is not a good predictor as far as prognostication is concerned. So don't go through a motor movement that your patient doesn't have any kind of motor movement, because it carries a false positive rate of 10% around. So that is why its level of evidence is also very low, that is class 3. Now, when you do a motor examination, that may be reasonable to identify the population who need further prognostication testing. Means later on you can buy more time to tell the prognostic outcome. Now, what about myoclonus? Myoclonus is one of the most important thing which we see, but again it carries a false positive responses around 5%, which is a distinct from status myoclonus. But here again, if it is there, you can say that the prognostic outcome is poor. And another important thing is a status myoclonus. Status myoclonus is then during first 72 to 1 in 20 hours after cardiac arrest is a reasonable finding to help predict poor neurological outcomes. So myoclonus, status myoclonus, motor movements, pupillary signs, these are all important things. Then what you are going to get in EEG? If you are seeing the EEG, what are the things you will see? Who are treated with targeted temperature management, it may be reasonable to consider or predict absence of EEG reactivity. If you see, obviously that has to be there. And then there is a persistent burst suppression of EEG after rewarming. So once you rewarm, if you see there is a persistent burst suppression, it carries a class 2B recommendation. Then intractable and persistent status epilepticus in the absence of EEG reactivity, that is again a poor prognostic marker. And after post-cardiac arrest who are not treated with targeted temperature management, it may be reasonable to consider the presence of burst suppression after 72 hours of proper management. If you look into this, so EEG, what you see, that isoelectric EEG or burst suppression, if it is there, that means the patient carries a bad prognosis. What about evoked potential? It says consider bilateral absence of N20 SSEPP signal with 24 to 72 hours after cardiac arrest, and that is again a bad prognostic marker. Now what about imaging tests? You do a CT scan or MRI. So there is a gray-white demarcation or gray-white ratio which is there in the CT scan. So if you see there is a marked reduction in the gray-white ratio, it is usually has to stay above 1.2. I mean it comes down below 1 or so on brain CT obtained within 2 hours after cardiac arrest to predict a poor outcome. And there is an extensive restriction of diffusion on MRI at 2 to 6 days after cardiac arrest. So if there is a restriction in diffusion weighted MRI, then again you can say that patient carries a bad prognosis. So these are the imaging markers. Then what about blood markers, which we are looking? We are trying to search some more new markers, but some of those have been tried. One is neuron specific enolase and another is S100 calcium binding protein B. These two biomarkers have been found, but their reliability is not much and they come under class 3 commendation. But at present they say that if they are high after 48 to 72 hours of cardiac arrest, they are a good predictor of poor outcome for any patient who has undergone cardiac arrest. Now what about organ donation? As I said, all patients must be promoted to give organ donation, and that carries a class 1 recommendation. And patients who do not have return of spontaneous circulation after resuscitation efforts and would otherwise have a termination of efforts may be considered candidates for kidney or liver donation. If not all, so kidney and liver can be donated. So the useful, if you summarize all of them, so one is pupillary reflex. There are 2 clinical findings: biological marker, EEG finding and imaging. So these are the 6 points which we actually remember, that pupillary reflex, status myoclonus, then somatosensory evoked potential, gray-white ratio. As far as MRI, the restriction of diffusion on brain MRI, and then absence of EEG reactivity and burst suppression. So all of them On the basis of one, you cannot say patient carries a good outcome or a bad outcome, but you have to combine all this, then only you can say that patient carries a bad outcome. Now we come to our focus on targeted temperature management. Where are we heading? Where are we today? What is the status? Current status. We'll talk about that. So this is, I am not going to the detail, all of you must have read how to do it and what are the instruments which is required, how to initiate, how to continue and how to exit or come out of this. So I am not going to do it. Let us first see to the guidelines, what guidelines say. If you look at the American Heart Association guidelines 2015, what it says that all comatose adult patients with return of spontaneous circulation after out of hospital ventricular fibrillation or pulseless ventricular tachycardia, cardiac arrest should undergo a TTM management with a goal temperature of 32 to 36 degrees centigrade. And that carries a class 1 evidence. And second recommendation is that adult patient with return of spontaneous circulation after in-hospital cardiac arrest. So both out of hospital and in-hospital cardiac arrest, they must undergo through this TTM. This is the recommendation and the duration is 24 hours. The target temperature which is to be maintained is between 32 to 36 degrees centigrade. Then what ILCOR says? 2015 recommendation, they says that target temperature management with goal temperature of 32 to 36 for at least 24 hours should be part of standardized treatment strategy for comatose survivor of cardiac. So they generalized the statement and say you give it for all. Okay. Now what about European Resuscitation Council? What they said as far as targeted temperature management is concerned, they said if the cardiac arrest has happened out of hospital, then initial shockable rhythm will remain unresponsive after return of spontaneous circulation. They are the good candidate. And again, patients who have non-shockable rhythm who remain unresponsive after return of spontaneous circulation, they are another candidates, but that carries a weak recommendation, whereas the first one carries a strong recommendation. The third point is that any initial rhythm who remain unresponsive after return of spontaneous circulation, that is again a weak recommendation. And if targeted temperature management is used, it is suggested that duration of at least 24 hours should be given for all those who are receiving targeted temperature management. Now, let us analyze, okay? So from where it started, it is almost 60 years back. It was Peter Shafar. You know who was Peter Shafar? Yes. So it was Peter Shafar who actually described that this induced hypothermia, and he included the induction of hypothermia for patients who do not show any signs of neurological recovery after 30 minutes. So 60 years back it was started. At that time it was felt that cooling below 32 degrees C was necessary for benefit, as these temperatures were already utilized for preservation during cardiac surgery. We all know that cardiac surgery it is a common phenomenon which everyone follows. So the idea was that decreasing brain metabolic needs with hypothermia could allow better matching of oxygen delivery and consumption. Yes, this is a fact today also. And consequently, induction of post-resuscitation hypothermia did not become widespread for many years. Why? Because this understanding of Peter Shafar could not be percolated amongst the scientists who came thereafter. Now in 1980s, after 20 years around, laboratory studies demonstrated that mild cooling 33 to 34 degrees centigrade was beneficial as compared to normothermia or cooling to lower temperatures, though it seemed that the cooling had to be induced very quickly. Look at this wording, had to be done very quickly after restoration of spontaneous circulation. And this was published in Stroke 1992 and one of our journal, that is Critical Care Medicine, 1993. Now what happened after that? In 2002, after 10 years, there are two randomized control trials that both of them came in New England Journal of Medicine, and they demonstrated that a cooling of to 32 to 34 degrees centigrade for around 12 to 24 hours improved outcome. But here what they did, even though cooling didn't begin for over 1.5 hours and target temperature wasn't achieved until 8 hours after return of spontaneous circulation. So how this study could have been done, you can very well understand the fallacies which were there. Previously, it was said that fast cooling has to be done, and here in these studies, it could not happen even up to 8 hours from the starting because nobody was knowing what is the rate, how to do it, and okay. So the results of these trials had an almost immediate impact upon all critical care specialists, and everyone started following that. Oh, outcome is very good, very good. So entire world started following this. That yes, if we do an induced hypothermia, the patient's outcome are much better. So this happened. Now, what are the questions against these above studies? After that, people realized that yes, the outcomes are not so good, which has been written in the journals. So then lots of questions started coming. So many patients in normothermic group may have actually been hypothermic, which is a well accepted to be associated worse with worse neurological outcome. Many a time you have seen that the temperature rises, and at that time you are trying to cool the patient. And another important thing, that many patients were enrolled at 35 degrees centigrade, and rather than cooling, they actually required warming. So from 35, the temperature has to be taken to 36 to attain the target temperature. And the study demonstrated no outcome difference at 33 and 36 degrees centigrade group. So these were the questions, and then in these studies, only one time of initiation of cooling and one duration of hypothermia. So they tried to say that one size fits for all. That fix the protocol and say it will fit for all. So that is not again correct, because today we are progressing towards individualized therapy and individualized patient care. So hence it leaves clinicians with important questions that they have ignored about the most appropriate timing, duration and depth of hypothermia. All of them are very important for individual patients. So the optimal duration of target temperature management remained unclear, and in one laboratory study, 48 hours of hypothermia reduced neuronal degeneration of 24 hours, and this was published in 2011 in Critical Care Medicine, that 48 hours is better than 24 hours. Now what happened after that? There are two animal studies which were done. One was done on small animals, and that they revealed that a potential greater neuroprotection when therapeutic hypothermia was maintained for 48 hours as compared to 24 hours. So till date, all recommendations are in favor of 24 hours. In larger animals, another study was done. It was again published in Critical Care Medicine 2014. They said 48 hours of therapeutic hypothermia was more effective in attenuating brain apoptosis, which is better. In humans, out of hospital cardiac arrest, this approach was supported only by retrospective data. There is no prospective trial from small cohort studies. So, in a small number of patients, return of spontaneous circulation after pulsed electrical activity or a systole or prolonged ventricular fibrillation, it was shown that a prolonged hypothermia for 72 hours may blunt the inflammatory response after rewarming. So there are a lot of things which get suppressed with hypothermia. So we'll see that. This was another heroic study. It's a big study, 950 patients enrolled by Nielsen. And what he found after doing the study, again he tried to find out what is the appropriate temperature, duration and everything. And he said that in unconscious survivor, out of hospital cardiac arrest or presumed cardiac cause, hypothermia at a targeted temperature of 33 degrees centigrade did not confer a benefit as compared with target temperature of 36 degrees. Very recent trial and very famous trial. Now, in an attempt to define the optimal duration, Kierkegaard, he published last year, 2017. This was a very famous study which came in JAMA 2017. And what he tried to again prove whether 24 hours is better or 48 hours is better. And for cooling of 33 degrees centigrade for a comatose survivor. And what he said, and he again took to cool all his patients around 5 hours, standard time to cool. So it was not a quick cooling. It was again a very slow kind of cooling. And what he said, that no difference in long-term favorable neurological outcome as far as CPC scoring is concerned, 1 or 2. And or mortality or hospital length of stay, and adverse outcome are more common with more prolonged cooling. So on the one hand, these animal studies are in favor and these human studies are going against that. So the only significant limitation of the above trial was this was a very good trial they started. But what they did, they found that okay, we are already getting benefit at 33 degree and 24 hours. Why to proceed? They just abandoned the study and they closed that study very hurriedly just by enrolling 355 patients. So I think that could have been prolonged and they might have enrolled around 1,000 patients to come out with a very good trial. So time to target temperature has not corrected with outcome in all those trials. And one of the confounders with looking at cooling time is that patients with more severe neurologic defects tend to cool faster than those. Obviously, patients who are having more injuries, they tend to cool faster. Now, this is another study, 2016, and they try to find out that, what about this non-ST elevation MI patients, because cooling is mainly recommended for those patients who are, they did this study in setting of non-shockable cardiac arrest, out of hospital, non-shockable cardiac arrest patients who develops arrest out of hospital. And they found that 14% patients receiving targeted temperature management versus 5%, means there was a good difference in outcome in those patients also who developed non-shockable rhythm, means pulseless electrical activity or asystole. Their outcome is also better. Rather than all those trials which were done previously, they said, it is good for shockable rhythm and not good for non-shockable rhythm. But this was one study which suggested that it is good for patients who had non-shockable rhythms also. So this is all about the studies. So what are the thoughts for future research? Now, with good laboratory data to substantiate this hypothesis, it would be difficult at this juncture to justify a study of even more prolonged TTM, because we see they have gone up to 72 hours, but as far as benefit is concerned, nothing was there. There are clearly risks associated with more prolonged hypothermia, including shivering, coagulopathy, infections, because all of this increases. So you have to take into considerations all this, and one could monitor the intracranial pressure and cerebral oxygen consumption by putting a device into the intracranial cavity, but that will be an invasive thing. I don't know, somebody dares to do it in future or not. But again, it is typical to utilize fairly narrow inclusion criteria. That is very important. But in emergency, it is very difficult. Why? Because whenever in emergency a patient comes, till the time you explore the details of the patient, that is by that time it is too late. So narrow down the inclusion criteria is a very difficult part in critical care research or research which undergoes in emergency management. So that is again one of the important things. That is why the results are biased. And again, biomarkers are already been tested and trial in the laboratories. They are one of the things which can actually differentiate. And there are many targets which are actually suppressed by hypothermia. We have to take into considerations all those like free radical production, apoptosis, mitochondrial dysfunction, inflammation, neuroexcitability, vascular permeability. All those things has to be taken into consideration when we are doing such kind of trials. So finally, to conclude, target temperature management as currently recommended, as you saw that AHA and European Council has recommended, improves outcome in comatose survivor of cardiac arrest compared to no temperature control. Obviously, we saw the advantage. So far, we have not determined any timing of initiation, at what time it is to be started, specific temperature target, what is the best temperature which we can actually try to go at, or the duration, for what duration exactly we need to do it. And that will definitely, if somebody does it in future, will have a good impact. Thank you very much.